Hello, I'm Sherry with the CGH Health Foundation, and welcome to our Growing Healthier program. This educational series is sponsored by the CGH Health Foundation. In our Growing Healthier programs, we educate you about important health topics, and we also take the opportunity to introduce you to some of our knowledgeable health professionals. Our programs are hosted by Dr. Bill Bird, our Chief Medical Officer at CGH. Dr. Bird's guest today is Dr. Eric Coons, family medicine practitioner in the CGH Main Clinic. Dr. Coons is really good about keeping an eye on public health trends, and one that he's noticed and wanted to talk about today was the continuing problem with drug overdoses, opioids, both fatal and non-fatal. A couple of things before I turn it over to Dr. Bird. I wanted to let you know that the CGH Spring Auction is coming up, and it will be held from May 2nd at 7 a.m. through May 7th at 8 p.m. Our auctions are done virtually on the airauctioneer.com website, and so that's where you go to place your bids and to look at the baskets, and you can also view them in person at the CGH Health Foundation offices at 2600 North Locust during the time of the auction. Next month's program is going to be all about eye health. May is Vision Month, and we have a new vision provider or ophthalmologist at CGH, Dr. Robert Pody, who's able to bring us some new procedures. And so Dr. Pody will be with Dr. Bird next month on May 30th, and that will air live on Facebook at noon. So, Dr. Bird, are you ready to get started?
Oh, yeah. How you doing, Sherry? Okay, so hey, Bill Bird, Chief Medical Officer here at CGH. Thank you for taking the time to join us. And Dr. Coons and I are going to talk about opioids. And gosh, it's been a few years ago that Dr. Coons, I think he did a talk about opioids and was very involved in that and still is. And it's been a while. It continues to be an issue. And I thought it'd be helpful to pick his brain about what's going on with opioids. And so, Dr. Coons, let's get him on the line here. Hi, Eric. How you doing?
Hi. Hey, Bill.
Thanks
for having me aboard again.
Yeah. Always good to have you. So yeah, let's get to it and start talking about opioids. And Dr. Coons has some nice slides that he's put together too that I think will help for those of you who are watching. So let's just start with your perspective on how we're doing as a country on with opioids at this time.
Yeah. So the little illustration here just kind of sums up a good illustration of what it feels like to be stuck in that situation, and maybe how we're doing as a country too, which is we're kind of on fire at the moment. There was kind of a step change, it seems like, with the pandemic and isolation and kind of lack of social connections that have really spiraled this more, and the availability of synthetic opioids have really kind of fueled this quite a bit. So if we could advance to the next slide, we'll
is that how your brain looks, Eric?
on certain days, yes.
That's how mine looks a lot of the time. So, all right, I'm sorry for interrupting.
No, it's all right. Yeah, when I saw that, I'm like, boy, that definitely resonates, that picture. So this just kind of gives some illustration to the rapid rise. You can kind of see things were gradually increasing through 2019, and then 2020 and 2021, opioid deaths really increased. And 2022 is significantly worse yet, unfortunately. The other interesting thing is, men always make poorer choices than women, as you can see in the yellow and orange line, but it seems like that's separating even more. So we're getting worse that way, and I'm not quite sure why that is, but it's definitely a pretty significant difference. So, all right, moving on to the next slide. There's a little bit more detail there. Again, this is showing just a little bit more of the separation between men and women. So in terms of clinical stuff, we just need to have our radar up a little bit more. People who are, being male is a risk factor. So when we're thinking about what risks are we taking and starting narcotic medications, we got to keep that in mind. So, okay, moving on to the next slide. So this I thought was really interesting because it really illustrates how things have changed. If you, it's kind of a busy graph, but if you look at the blue line, that is the synthetic and opioids other than methadone. So largely fentanyl. That was pretty quiet up until about maybe 2015 or so. And then you see another step change around 2019. And that's really fueling it. It is so potent. I read a statistic that the amount that's in a Tylenol is several, like if just the amount of milligrams that would be in one Tylenol is several hundred lethal doses for people who are not tolerant. So
Wow.
the potency and the availability has just really made things difficult. The other thing to see, though, is if you look at the bottom green line there, people on the methadone program continue to do well. In fact, if anything, those overdose deaths involving methadone seem to be not increasing and maybe even going down a bit. So those treatment programs continue to work. It's obviously involves specialist personnel and people, but it is the way that we keep people safe. And we'll talk a little bit more about other options as well. But I think that's important to see that despite the overall trend being up, it's very specifically driven by these synthetic opioids. Heroin and the prescriptions are not really driving this current wave. We'll talk a little bit about how we got here later, and they're involved some with that. But it's the synthetic opioids. It's a real issue.
Yeah.
All right, moving on. So I don't want to spend a lot of time on this, but there's a lot of methamphetamine issues. It's not really the target of today's talk, but what I wanted to point out is if you look at the yellow line in that's psychostimulants combined with these synthetic opioids. And you can see that is a step change as well, starting a little bit around 2017, and especially after 2019. The death rates, if you're mixing the stimulants and methadone with the synthetic fentanyl, that's really driving a lot of overdoses, is mixing those two together. And so that was something that really impressed me when I was looking at the data is that's a big part of the issue. And when it comes to clinical stuff, what it reminds me is we probably should be paying even more attention to just doing routine checks to make sure our patients aren't getting involved with other forms of narcotics, and sometimes even inadvertently. We've seen marijuana laced with fentanyl because marijuana dealers, they're unfortunately in some ways good businessmen, and if they put just a little bit of fentanyl in there, it makes for better customers, people that come back, and it's dangerous, unfortunately. So kind of for us as clinicians trying to get back to being a little bit more diligent yet about screening for that stuff. And it's tough because it makes patients feel like we don't trust them, but it's an important message that it's just something we need to do as a routine, because we get surprised and our patients get surprised sometimes. They think they're just getting a little bit of marijuana to calm themselves down, and what they're not realizing is there's more in it than they realize. So, yeah. All right. So this is opioid deaths just from the amount the amount involved these synthetic opioids is a lot. In the interest of time, I'll probably skip by this one pretty quickly here too. If we can go to the next one. This is what again kind of drives home that point. Look at the difference between the synthetic opioid deaths in 2013 and 2022. It's the issue. It's the big issue. Heroin deaths have actually decreased some. It's mostly that issue. So moving on, one more slide here. I thought this was interesting. In 2019 was the first time that we had more deaths from opioids in car crashes. And just between 2019 and 2022, we now have more than 2.5 times the deaths from opioids versus car crashes. It's a tremendous change in a short period of time.
Yeah.
All right.
Very sobering.
Yeah, I think we've hit that home pretty hard, but I think it's an important point. So
yeah, very good.
Now we can move on to the next question. This is just in Illinois. It's the same thing in Illinois. We're seeing tremendous increases.
Sure. Okay, well let's talk about this then. Before we get to that slide, there are patients that do benefit from opioids still.
Yeah.
So Dr. Coons, what are the kind of patients in your practice that are still patients that you are prescribing opioids for?
Yeah, that's an important point, because we don't want to lose the fact that we can throw the baby out with the bathwater in terms of being diligent about this. And one of the important lessons of this, when this first started to come to light, and we started really kind of, for lack of a better term, kind of cracking down on people who were having irregular filling habits and stuff like that. What we didn't find is that we were making people necessarily safer and better if we cut them off abruptly. In fact, that often led them to turn to street narcotics and those issues. And those people often ended up in more trouble and not less. So we really try and work with people and try and manage things rather than saying you've broken the rules, therefore you're done. So to your point, there are people who have chronic pain that we've tried all the other options for, that have end of life issues in particular, and people who really would struggle to do the daily activities that they need to do, or maintain some level of exercise without medications to help. And we really focus on trying to make sure these medications are allowing you to function rather than just kind of drowning the pain or sorrows. That's an important distinction and something we really try and follow. So there is a place for this. And there's also a place for trying to work with people outside of their comfort zone a little bit. And we'll get to that a little bit about how people inadvertently get into trouble and how they can manage that a little bit later. But there is definitely still a place. We really try and focus on how does this improve your function in meaningful ways, and how do we balance that against the risks that we're taking, and every patient is unique that way.
Are there any other treatments that you've been kind of being proponent of for your patients outside of the opioids to try to help and manage that pain that have been working or that you've seen some success with?
There's been a lot of advances, and that's kind of in two areas. One is trying to do things so that we don't have to start people on narcotics to begin with. So advances in perioperative pain management, nerve blocks, starting Tylenol and those medications ahead of time, using some other what we call adjunctive therapies, things that modulate pain, and also just working with people that it's okay to work through certain degrees of pain. We don't want people miserable, but shooting for zero pain is probably not reasonable in all these circumstances. So there's been a lot of advances in perioperative management of pain, where we don't expose people to begin with, because we become much more aware that even inadvertently, that's often where people get the start into trouble. They're not looking for trouble, but they have a high risk background. They have a genetic tendency towards these medications being habit forming, and they inadvertently get into trouble. So that's one. The second one is, how can we manage pain in people who already have chronic pain? They may already be on narcotics, and they're a high risk person. They have COPD, they have sleep apnea, they have things we worry about.
Yeah.
So multimodal pain management, meaning we employ multiple different types of pain control. So things like gabapentin, pregabalin, working with topical anti-inflammatories like Voltaren, oral anti-inflammatories, and being creative about when we use these and how we manage those. Some of the antidepressant medications are helpful that way. We find that cognitive behavioral therapy, how you mentally address pain and work with that, are really important as well.
One of the things that you mentioned when you were answering this question, Dr. Coons, was there's a genetic predisposition for some folks in terms of risk factors. And already you'd also talked about that being male is a risk factor for becoming opioid addicted. Are there any other risk factors that come to mind that people should be aware of?
Yeah. And, these need to be clear. These are not people's fault. You can't pick your parents, right? Sometimes we wish we could, but there's a lot of things that make a difference. We have to keep them in mind. And it doesn't mean we necessarily do or don't do things, but we have to be mindful of them. So things like a family history of alcoholism, family history of drug abuse, other sorts of medication use and overdoses. Depression in and of itself is a risk factor. Again, not people's fault. We just have to be extra careful, and we want to make sure we have those risk factors managed as well as we can when we're thinking about engaging in what would otherwise be a higher risk medication management. And sometimes it affects which one we choose, because some medications are less risky to get people in trouble down the road.
Yeah.
But,
I remember a talk that you gave, gosh, it's been several years ago. And speaking of risk factors, and I think you said something about, it's something to do with, like, for every day that a patient is on an opioid, their risk of becoming addicted to it goes up a certain percentage. I think it was like maybe post-operative pain, or I forget what it was. Do you remember what that was about?
Yeah, boy, I wish I could remember the specific statistic, but it is.
It was like 1% a day for every day that someone was.
And there's a slide we'll get to in a little bit that kind of really illustrates how this process happens and how good people can end up in trouble. And that's an important point. This is a calculated risk every time we do this, and we need to be mindful and think hard about that. People are coming in and I just want something for the pain, and we get that. We just have to be very careful and mindful that when we take this step, it's a little bit about like saying, well, you need chemotherapy now. We really need to think hard about, are we really there? Have we exhausted all the other options? If we're going to enter into this, how do we do it as carefully as possible? Because, there's a significant percentage, somewhere, around 1 in 100 of all comers, and this is not just high risk people, end up with a problem once we expose them at all. And if you're a high risk person, now we start getting into the number needed to harm to maybe only be 10 or 20 people. Every 10 or 20 people in a high risk situation that we start on this, we inadvertently send them down a path to trouble.
Yeah. Well, let's get into that. Let's get into the process where someone could become, where they get dependent or addicted on an opioid. And I think you have a slide that illustrates this. So let's take a look at some of that.
Let's move along a little bit. This is the one that I think helps illustrate that some. So this is looking at what you feel in terms of the middle green area is just normal baseline. The blue area is, geez, I feel kind of, good. Not just, I'm managing my pain, but I feel a little good. And the yellow to red area is, I'm feeling worse than normal. It's making me, I'm having a bad day, so to speak. So when you start on the left-hand side and you take that first dose, especially for people who have this, they're wired so that they're a little more tendency towards, getting euphoria from this. Everybody reacts differently. Some people don't get this much, and we can get some idea of the risk, but it's not a definite thing. We don't know for sure until we get there. But if you get that thing where, geez, I feel really good with this, that kind of sticks in your brain that that I've maybe not felt this way before, and it's my life is kind of dull and gray, and this is better. So in the beginning, you feel good, and then after between doses, you go back down, as you can see. And the next dose, I mean, this is condensed a little bit. It's not each individual dose, but over time, those doses start to get you a little bit less. Well, what you feel is, yes, I feel better than before, but over time, you start not getting quite as good as you used to be, and over time, you start to struggle to get to certainly above normal, and eventually, you really struggle even to get back to normal. And between doses, you start feeling kind of significantly worse than normal, and what people the natural tendency is, geez, if I were off of medication, this is my life now. I'd feel like I do at the bottom red squares there all the time. And they know that when they take their medication, they go from feeling poorly to kind of okay. But what is less apparent, because it's kind of a boiling the frog sort of thing, is you've gone down this path of this medication has moved me down from feeling good to normal to now I'm only getting to normal, and I'm getting worse than normal between doses. So what typically happens is you really want to go back to the beginning. So you elevate the dose, and for a little while that gets you back up to the beginning, but you keep riding this path down, and the bottom keeps getting lower because the dips between doses keep getting worse. And then if a provider says, oh, you're in trouble, and we take you off suddenly, that's where that big deep into the red is. And people are like, I don't want to be here at all. This is terrible. I don't want this to be my life now. And there's a lot of catastrophization that, geez, this is how life is going to be. And this is where we really need to work with our patients and say there's ways that we can make it so it's not so bad. We can work with you much more slowly and not send you into that bad area. But the important point is you can work your way back up this curve through slow tapering without going through that big dip, right? If we slowly work your way back up, then those extra receptors that you've built start to work their way back down, and you get to be better again. Right. It takes time and it takes some work, but if we really work with that carefully, we can make people's lives better. And the people who've gone through this often are like, geez, I didn't realize in the moment just how cruddy I felt between the doses, that wasn't normal for me.
Yeah.
The one other thing real quickly that's real important here to see is when you have a life stressor, that takes you back down into the red. And it's a very big risk factor for relapse, because the only thing that's going to get you rapidly back to feeling good, and this is kind of hardwired in now that you've had that exposure, is what your brain remembers is, when I felt this way, the one thing that made it all go away really quickly is that medication. So that's a really strong trigger to go back. So when people are better, we really need to spend some time saying, this is what we got to be really careful about these times.
And that's a good segue to what I want to ask you about next. And that is, there's definitely a trend these days for some medication that can help to prevent this curve that we're seeing from occurring, to stabilize it, if you will. And that's one of those products is Suboxone. What's the latest on medications like Suboxone and how they're used and how they're being used to treat patients who have what is called opioid use disorder?
Right. And let's define opioid use disorder kind of briefly in lay terms.
Sure.
It basically means that if you have opioid use disorder, you are engaging in activities that are in some way harmful to you or not in your best interest in order to stay on the medication. So You may be taking risks in terms of how much medication you're taking, using medication even though it gets in the way of your job or your daily life, those sort of things. So it doesn't mean you've got a needle hanging out of your arm and you're an addict in the street. It just means that there, at some level, these medications are doing you harm or causing you to do things that are not good for yourself in order to stave away that feeling of going into withdrawal.
In some ways, it's similar to the questions we ask someone about in terms of their alcohol usage.
Right. And again, not everybody that has trouble with alcohol, in fact, most people who have trouble with alcohol are not bums on the street and, look like your stereotypical alcoholic. It's much more subtle than that. But so for those people, it's really tricky to keep people from ending up in trouble, especially if they're starting to get into any of these super potent synthetic opioids that we talked about in the beginning, because they're so potent. We've heard about the police officers who are trying to resuscitate somebody and they go into a cardiac arrest just because they've touched somebody who has this on them. These things are so potent, it's tough to get a safe dose in. A difference between what the effect they're looking for and an overdose is, a grain. It's just, it's tiny. So the risk of getting into real serious trouble becomes really high. Medications like Suboxone put a ceiling on that. So they have a partial effect. So they get you some pain relief, but at higher doses, they actually block those receptors. So they can do two things. They can keep you from getting in trouble from that medication, but even more amazingly, they will have some protective effect at keeping you from getting in trouble if you have a break and you get on one of these other semi-synthetic opioids. They will block that to an effect. Now, if you use a big enough sledgehammer, you can still overdose, but it's much harder to do. So just like in that curve we saw with methadone, it tends to keep people safe. People really do end up in a lot less trouble. But it's been tough to get people on these because it's tricky to make that transition. If you're on a significant doses of narcotics and we just start you on this at a regular dose one day, we send you into a sudden feeling of withdrawal that's very uncomfortable. So the starting point is a little bit tricky, but once we get beyond that, people function better, their pain can be managed, and they don't end up dead.
It levels out that graph that you were showing. It kind of puts you more right in that middle zone if you're on Suboxone.
Right.
So let's talk about what is in place right now for those folks who are interested in that the state of Illinois has to help and to get people get them the help that they need.
Right.
Talk about that a little bit, Dr. Coons.
Yeah. So there's quite a few different avenues to seek help. So I think getting started is appropriately more available than it used to be. There's still a bit of a challenge, as far as getting everybody hooked up to the people that they need when they need it. But starting that process is definitely possible, and it's a lot better than it used to be. So this Illinois helpline is a very good place to start. This 833-2-FIND-HELP. They can connect you with people who can help you get on Suboxone or find a methadone program. And boy, I mean, the stigma of, in particular, methadone that's for heroin addicts. I'm not a heroin addict. I don't need that. But for people who are in trouble in general, or even sometimes, people who are just really high risk, they have, they've got a strong family history. They, maybe they've had some other, addiction issues in the past. Even cigarettes is a risk factor for this. But if you're a high risk person, maybe we start you on these medications so that you don't end up accidentally going down that road, because that's part of the way it happens. There is also our own Ways to Wellness program locally. They can also, through your doctor, help you get connected with people who can help you through the process on a one-on-one and personal basis as well.
Yeah. And I had an opportunity to talk to one of the doctors who leads this program through the state, and they try to make it as seamless as possible. If you need Suboxone, they will get you started on Suboxone, and even you can take it oftentimes in your home to begin that process. And then the follow-up medications, they'll get those to you as well. So the state is recognizing that this is a significant issue. It's a public health concern, and I think this is a really good start in terms of trying to help folks in that regard.
Yeah, the health department is there too. We got a helicopter coming in, so it might get noisy on our end here, but
yeah.
But I can't emphasize enough that this is a massively growing problem, and having a physician's assistant whose husband is a police officer here, we kind of get updated on that end of things, and it's definitely a problem in our community right now, and it really is devastating for the patients, the families. People really struggle because they don't want their kid on the street, they don't want their kid without support, but it can be really tough. So please reach out to your primary care doctor, the health department, the helpline, all those sort of things.
Yep.
And one last thing, and they're bringing up this. I think it's a big enough problem that I know after researching this, I'm going to make sure that I have some over-the-counter naloxone. There's nasal sprays that you can get. This was made, you can walk into any pharmacy and get it. These agents are very safe to use. So if there's someone who's blue or not breathing, and any concern about an overdose, it's much safer to go ahead and just use the nasal spray or whatever it is to try and reverse this. If you're wrong, there's really no harm done.
Right.
If you're right, it may reverse it, and the person may get very uncomfortable, but they're going to live. So I think it's worthwhile for us to all think about having this readily available, because it's becoming a big enough problem that we may run into this just in our daily lives.
Yeah. I'm sure the police carry that on them. And, obviously it's one of the ways to try to help folks, if you can catch them before they've completely overdosed, is they have that naloxone. So not uncommon for for folks to begin prescribing naloxone along with the opioids that the patients receive.
Yep, I do that quite a bit. And again, it's not because we think you're a drug addict. Maybe it's not even you. Maybe somebody finds it and you inadvertently they overdose on your medication. You want to have an option to fix that the best you can.
Yeah. Well, Dr. Coons, as always, it's really good to have you, and you're obviously very full of information about this opioid situation. And I know we'll have you back because there's other things that Dr. Coons is pretty knowledgeable about, as well as we might talk about opioids here in another year or two, just to see where we're at. So, Dr. Coons, thanks a lot. Appreciate your time.
Okay, Bill. Take care.
Okay.
Good luck, and be careful out there.
Thanks. Okay. So very good information and talk. And please feel free to share this with folks that you think might find this helpful in terms of information. This is obviously pre-recorded, so we weren't able to do the questions during this talk. So sorry about that. It just worked out in terms of our scheduling. I do have a few other announcements to make, and I know Rebecca's going to put some things up. So I wanted to congratulate Barb Smith at Ready Care, a receptionist there. She's our employee of the month. So congratulations to Barb. Speaking of Ready Care, this is a new way that you can kind of find out where your slot is at in terms of going to Ready Care. You don't have to sit in the lobby necessarily to know where you're at. in terms of your turn to be seen by one of our Ready Care providers. So I think that's going to be, we've already been implementing that, and we've gotten really good feedback about that. And I'm trying to think if there was anything else you wanted me to mention, Rebecca. Yes, organ donation. That's April 22nd at the main clinic atrium. I really encourage folks to do that. And yeah, just to reiterate, Dr. Pody I'll be interviewing Dr. Pody next month, and we'll be talking about vision and how to have healthy vision. So looking forward to that with Dr. Pody. I think that'll do it for us. Until next month, thank you for watching, and we'll see you soon. Bye.